Hi, everyone. It's David. Welcome to this bonus session for the Advanced Trauma-Sensitive Mindfulness course. This session is titled Mindfulness, Trauma, and Chronic Pain, a conversation with Jackie Gardner-Nix and Alan Steverman. This is a session that's designed to explore the particular relationship between chronic pain, mindfulness, and traumatic stress. And Jackie and Alan are international experts in this area, and I thought would be the perfect people to have here and engage in this conversation. I'll just tell you a little bit about Jackie and Alan. So Jackie is the medical director and founder of Neuronova Center for Mindfulness Studies, which is located in Canada. She's also associate professor in the Department of Anesthesia at the University of Toronto. And she's worked as a chronic pain consultant physician at Toronto St. Michael's Hospital and Sunnybrook Health Services since 2001. These are all actually hospitals that are just down the street from where I grew up in Toronto in Canada. Alan Steverman is a family physician who's in Montreal in Quebec. He completed his residency in family medicine at McGill University, and he's currently the attending physician at the pain clinic at the University of Montreal's medical center. And both Jackie and Alan have focused their own work around chronic pain, specifically around mindfulness. They both trained in mindfulness based stress reduction. They've both done a ton of work around mindfulness, and are two people and professionals who are doing work to explore this intersection between chronic pain, trauma-sensitive and trauma-informed practice, and mindfulness. And they just have years in of really hard-won insights about what's worked, what hasn't. Jackie in particular noticed that there were certain places that the traditional mindfulness-based stress reduction program wasn't working for her clientele, which is interesting given that MBSR was originally designed for chronic pain. So she's just been a really big conversation with MBSR over many years now, has created this program. Alan is also applying this with groups. So they're just two practitioners who have both a lot of theoretical knowledge and also just a lot of practical skills that came out in this interview. So it's a great discussion. I'm really happy at the way we both unpacked chronic pain, what we mean by chronic pain, its intersection with mindfulness, and then just some real tangible best practices around telemedicine, how we work in groups, how to not shame people. And I'm happy about what came out here. So I'm glad that you're joining us for this session on chronic pain and mindfulness, and I hope you enjoy it. Well, Jackie and Alan, thank you so much for taking the time to be here and have this conversation. I've been looking forward to talking to you about your work around chronic pain, your work around mindfulness, and then also trauma-sensitive and trauma-informed practice. So thanks for being here. And I thought we could just start with Jackie and Alan, you both getting to share a little bit about your story. There'll be a lot of people that meeting you will be new, and we can get into the piece around chronic pain. But how did you get to know each other, and what are you up to these days in the world? Jackie, do you want to kick us off?
Yes. So I'm a focused pain practice physician, and it was many years ago that I was doing that practice in a couple of the Toronto teaching hospitals, and I had come from palliative care as a background. And it clearly wasn't working so well, applying pain management strategies to those who were going to be continuing to live. And I was finding that such interventions as with narcotics and the other drugs that we use, the non-narcotic drugs, I wasn't getting that far in terms of enhancing their capabilities and their quality of life. And I encountered a patient who was doing mindfulness, and that's how I found out about mindfulness. This was 1999. So I looked into it and went down to Omega campus in Rhinebeck, New York, to do the 7-day course with John Kabat-Zinn. I'm a very conventional physician, conventionally trained in Britain, but working in Canada. And at first it was a big ask to kind of switch to this, but it really made sense. And so when I returned, I got permission from my heads of department in order to provide mindfulness for the patients that I was seeing in the clinic. So very gradually I got off the ground. I had to get off the ground with my own practice first, meditating regularly, and using a preceptor at first to help me run courses for my own patients. the MBSR didn't fit very well, and that's how we evolved into a different course called Mindfulness Based Chronic Pain Management. So that was my first intro, and we started running the courses in 2002 in 2 of the teaching hospitals, gradually going into delivering it by telemedicine to remote areas in Ontario as of 2003. So that's how I started out.
That's great. Some people will know this on the course that it's always heartwarming to get to connect with you both, given that you're both Canadian and that my family's close to both of you in some ways. And Alan, you and I met, I believe we were in Montreal. And then I think you connected me with Jackie and learning about the work that you've been doing. So thanks, Jackie. I love hearing about how you got here. Alan, do you want to jump in about just how you met Jackie and your work?
Sure. So I, as well, I'm a physician. I have a focus practice in chronic pain management, which I've had for several years. And I'm in Montreal, in Quebec. So the way I came to mindfulness work actually was a little bit different from Jackie's, in the sense that I knew about mindfulness and about Jon Kabat-Zinn's work before I actually started working in chronic pain. So this is early on when I just finished my medical training, and I was interested for personal reasons and did some training in mindfulness based stress reduction. Fast forward several years, I'm working in chronic pain management, doing a lot of the stuff that Jackie described, using this sort of traditional approaches that we have in chronic pain, and kind of realizing that they're one of the messages that we often try to convey to chronic pain sufferers is, is you'll now have to learn to live with chronic pain. And there seemed to be a large gap into offering them any tools to live with chronic pain. So I kind of had my own personal mindfulness practice and thought, I really wonder if any of this can be helpful to the chronic pain sufferer population that I'm seeing. So I started doing some research and trying to find out who's, although I knew Jon Kabat-Zinn's work in part was addressed to chronic pain sufferers, I was really curious to know, is anyone really targeting chronic pain population? So that's how I came upon Jackie's work, through some medical conferences and just through research. Connected with Jackie, had the opportunity to do a bit of some retreat work with Jon Kabat-Zinn at Omega as well, and then did some formal training with Jackie at her center in mindfulness chronic pain management programs. And then from there, brought the program to my hospital center, where I had a lot of support, which was great because it was a university hospital center where mindfulness was not at all on their radar, but they were quite open and willing to let me try it out. And so the program has been set up at that center and a little bit throughout Montreal since then. So that's where I got. That's
great. I have a couple questions that I'd love to ask you about what it's like to be offering inside of Montreal and Quebec, and just the general context there. And Jackie, I'd love to even back up even further to hear about how it went for you, or even for both of you for that matter, in the earlier stages. When we met, we talked about the interesting overlaps and parallels between trauma-sensitive practice and the way that it was really mirroring a lot of what both of you have been offering with folks that were struggling with chronic pain. So I'm curious, just how did it go? Did you bring this to Jon Kabat-Zinn and Mindfulness Based Stress Reduction? When you changed the name, I'm sure there'll be people that'll be interested in the history of it here.
Yeah, absolutely. Well, first off, bringing it back to Toronto, I was part of the Department of Anesthesia, even though I wasn't an anesthesiologist. So I was wondering whether my chiefs would even agree to this. But they were very open to it, right? And because I was an associate physician doing the drug work, as it were. So this was a big switch, but they were very open to it. They didn't want to do it themselves. Nobody did. They were happy for me to do it. And my first thought was to send my patients to MBSR instructors in Toronto. But I found that only about 5% of my clinic were sort of eligible because, for a start, geographically, they were more widely distributed beyond Toronto. And secondly, just trying to sort through who would agree to go was tough. And when they did go, they were coming back saying that they didn't feel they fit because of the yoga, because of the long body scans, and because they honestly didn't feel the instructors really got them, if you know what I mean. In those days, we're going back a long ways.
When was
so
this, by the way? Like around when
That
we
was
talking?
2002.
Okay.
Beginning of 2002. And so really you can imagine that most of the physician colleagues I had thought this was a little flaky, and they would really refer only when they had come to the end of whatever else they could think of. I mean, the average patient I saw had been seen by 17 other doctors before me.
Oh, wow.
For their chronic pain. So I started it up, but it was quite quick that I realized that a 45-minute body scan, which is what we did in those days, and the tapes of Jon Kabat-Zinn leading us in yoga were not really fitting the bill for this population of patients. They were very afraid of all of that. And they were good enough to come because I was leading it. So they were coming knowing this was new and that I would sort of listen to them about what worked and what did not work. And very gradually, I was beginning to change it so that the body scan was moved to later in the course. And we did very short meditations to begin with. And after about a year, we weren't doing the yoga. We were doing stand-up mindful movements with an eye to realizing that some people had to stay seated. People didn't want to be on the ground. People were quite happy with the compromise of standing mindful movements, some of which could be done sitting. And so things were beginning to feel easier for them. And I was beginning to glimmer that they were having issues with past traumas, such as flashbacks, nightmares, short medications resulting in what we would now consider to be hyperarousal. I didn't have the words in those days. And I was talking to Kabat-Zinn about this. I was talking to Jon because I went to his conferences every year, and I'd stop him in the corridor and say, Jon, MBSR is great, but not for my patients. And this is what I've done as a modification. And he would say, but we developed this for chronic pain. And so we certainly had some interesting discussions around that.
I'd love to dig in there actually around what was happening that would have you assess that it wasn't working for people, or I can imagine that would be a tension point given that MBSR was developed for chronic pain. And then I wonder if we could even just start, maybe Alan, if you could talk a little bit about how do you think about chronic pain? How do you define it? I realize this is a whole field that for many of us, this will be new territory. So could we just kind of unpack some terms here? How are we talking about chronic pain?
Yeah, sure. So I'll try to give you sort of a brief understanding of what chronic pain, how we view it, and maybe put it in the context of mindfulness, because I think the relationship is actually interesting. So by definition, chronic pain is any pain that goes beyond what we expect a normal injury or disease to heal. So, we have certain framework of when we think an acute injury or an acute pain should subside. When it doesn't subside, we call that chronic pain. Often we use 3 months, 6 months. It really depends on the context. The key here is that the way we understand chronic pain has changed quite a bit, and very recently, in the sense that our understanding of pain and our management of pain has often been based on our understanding of acute pain. So you break your leg, you go to the emergency room. That kind of pain is really easy to treat. We give you medication, we tell you not to walk on it for a few weeks, and it heals. A lot of the typical interventions that we do in chronic pain were informed by that type of practice. So we give medications, we do injections, we do therapy. Any chronic pain sufferers know very well that kind of intervention sometimes works to a certain extent, but it often doesn't work. And the reason it often doesn't work is probably comes from our much better understanding that in chronic pain, there seems to be something changing in the brain. So we really seem to be having what's called a central sensitization, where our brain is really becoming, in a sense, more reactive. And our understanding is that chronic pain, the reason we have such a hard time treating it is that it really has very little to do with the injury that you had or the site of injury. So it's not to do with your leg or your arm, but something has happened and changed in the brain. So as I was saying earlier, that leads, I think, to a better understanding of why and how mind-body therapies, and specifically why mindfulness would be helpful in chronic pain management.
Yeah, so this is great. This gets right to, Jackie, this is what you had just said about speaking with Jon Kabat-Zinn about the fact that mindfulness based stress reduction was really developed for chronic pain. Like you said about the number, that's amazing, the number of doctors that the people you were working with had seen before you. So often I think MBSR was kind of last ditch for a number of physicians and doctors to really work with the mind. So can either of you talk about, again, what are the modifications, both what were the modifications that you were making in the program, but then also the why? Like what was your response to when John would say, but hey, this was for chronic pain, but there's a way that you were seeing something that wasn't working. I'm just curious what it is that you were seeing or noticing that was suggesting to you that it wasn't working for people.
Well, the dropout rate.
Yeah, okay.
Right, the attrition rate was around 35 to 40%. And you see, people were coming referred by their family doctors or by their specialists in the clinics. And in their minds, they had a physical issue, and yet they were being asked to walk into a group that was going to be doing some mind-body work, which was, as Alan said, this issue of our patients being told by many doctors it's all in your head and you're going to have to learn to live with it, were a couple of badly worded phrases that they were allergic to. I mean, they did not want to hear that again. And almost by definition, walking into a mindfulness group, it was as if that was being sort of ground into them, that here they were again with that understanding of something was wrong with their head if they still had this chronic pain. So that was problematic, because I think in the States with MBSR groups, maybe people were choosing MBSR after getting to know something about it. And I think that they, actively sorted out and were coming to the groups, or maybe the doctors were referring them, but giving them some fairly good education about it. But ours didn't seem to be receiving education from their referring physicians, because the referring physicians themselves didn't know what we were doing.
Yeah.
Okay. So the first thing was not to insult them in the first class by doing such things as give them a raisin. Sadly, the raisin exercise was like a lead balloon, because people were feeling played around with. They were feeling not taken seriously. And so one of the first things that I found quite useful was something we call the supermarket scenario. And that was to describe going into a supermarket when you're in a lot of pain already. You go at a quiet time. You just want a couple of items. You want to get in and out fast. You go to the 1 to 8 aisle, and somebody in front of you has a huge number of items in the basket, in the trolley, and the checkout person is still checking them through. And how would you feel, and how would your pain be? And we would talk about that really early on in the first class as we started to modify things, because they realized straight away that their pain would be ramping up. And the other thing we sort of explored was, what was the story going on in your mind about the person in front of you and the checkout person? Mm-hmm. And they would be telling themselves a really negative story about these people, and how thoughtless they were about anybody that might be behind them that was suffering. But not only that, in chronic pain, when you've had it several years and your pain ramps up, it can stay there. It can stay at that intensity for hours to days. So instead of just, an hour later it's passed, or a few minutes later it's passed, our patients would suffer long term from something like that. And that very first class, if you get that in early, they begin to understand that there truly is a mind-body connection.
That's great. I never would have thought about the way that's the raisin exercise, the eating, the mindful eating. Is that right?
Yes.
I never would have thought about that being potentially triggering for people, and the way this is such a unique population. I actually have a question about that for either of you, maybe Alan for you, around shame. And when I think about, Jackie, you just said that around the folks that I know that have experienced chronic pain, the exhaustion of having that level of activated pain for sustained periods of time. And then, as you're saying, interfacing with different systems that might individualize or just make someone feel unintentionally, of course, make them feel ashamed, like it's something broken inside of you. So I imagine in your programs, you're the shames, it's there in the programs. I'm just wondering, is that true? And then how do you work with shame around chronic pain?
Sure. I'll jump in, Jackie. So, if you go back to the basic attitudes of mindfulness, right, and we're right in the definition, that John Kabat-Zinn's definition of mindfulness, you have the concept of non-judgment.
Right.
So that's a piece that's in the program early on and gets discussed quite a bit. And we go through, the different layers of judgment and non-judgment, but we certainly bring in, it's kind of strategically put at a certain piece in the program. Have you ever felt judged by others, including healthcare personnel, doctors, nurses, work colleagues, your family? And, we specifically allow a lot of discussion for that because that opens the floodgates. It allows people to share the, like that you say, it's shame or the judgment that they felt, which is important because I think it's important for them to be able to share with a group. And it's quite amazing because there's an inherent understanding among everyone in the group right away. And this is done pretty early on, but right away, everyone has a story they can share, and it really brings the group together. But we then take that after we've, given time to voice those experiences, then take it further and look, well, how has that had an impact on your ability to heal, on your current level of pain? And it really is an important piece that then becomes sort of at the core of what we're trying to help them work throughout the program, really.
Yeah. And do you open up group space? I mean, I can only imagine that has huge therapeutic benefit for people to connect, like, wow, you understand that I'm going through. Is there space for people to get to share with each other? And yeah, there is. It doesn't come out in the way of, completely unburdening themselves about what's happened to them,
right? Because that's not what we're there to do.
Right,
so it's not like group psychotherapy in that respect. But group is very important because they get to connect with each other, and we're very cautious to make sure that the groups switch. The small group work we do in many of the classes, that they switch to different members so that they all get a chance to connect with each other. That feeling of walking in their each other's shoes is huge in terms of healing potential and bonding, because they often feel very shunned by their families, very misunderstood by families, insurance companies, employers, and so on. So they really get a sense of becoming their own family, I guess, as they go through the course because of that common bond. The judging, though, as Alan said, so we learnt about what to put in what sequence gradually that made a difference. And that's where the supermarket buggy thing became the discussion around them judging others as well. And in the second class, they are also talking about what Alan pointed out, which is they're very judged by others, and they're very hurt by that because they're judged for not healing quickly or in the time frame everybody else thinks should be. But they're very judgmental themselves. And as we, progress through chronic pain and the experience of that, you can become very cranky and judgmental. And that allows us to say, and when you notice yourself judging, where does it go in your body? Okay. And that's where they begin to see that in their speed of judging and intensity of judging, that it lands in the body, and that usually that results in an exacerbation of pain and disability. So again, it's really building on the mind-body connection, taking them into noticing that on a regular basis, and then realizing that they can suspend judging, that there's a dialectic behind others, in other words, a story behind others who they're judging, which may be able to mitigate some of their judgment. And that really, really helps. Some people right from the get-go are saying, wow, I'm already seeing a difference.
Just that alone, that little bit more space between, that's fantastic. Again, this is why I was excited to talk to you both about the particular nuances that you've both learned. And I'm wondering on that note, given that you're both specializing in this field, could you talk about any mistakes that you've made over time, the development? I was having conversation with people that were doing mindful self-compassion work, and we're talking about on the path to it being trauma-informed, there was just inevitable moments in groups of understanding like, wow, okay, well, that term might not be the right one here, or we need to tweak this aspect of the program. So because this will be a lot of mindfulness providers and practitioners here in this group, I'm wondering if you can talk about just, your own learnings and mistakes that you've maybe made along the way that's improved the quality of the course.
Alan, do you want to start with that?
Sure. Well, I can give you some of the ones I've learned, and I've had the advantage of being trained and having Jackie recount to me a lot of the stuff that she learned along the way. So I'll
Right.
mix a bit of those in, but and I'm going to try to frame it because I imagine many people listening here are know about MBSR, and since this program was born from there, a lot of the errors, or not errors, but a lot of the modifications came from realizing that some things just didn't work.
Mm-hmm.
So you mentioned language. So there, and you talk about it quite a bit, David, in your teaching. So language and being cautious with the language we use has been a really important eye opener throughout the program. And some of the language that was, I guess, used in earlier versions of the program and feedback that was given to us made us realize that it really had to be adapted. And it can be language in terms of like basics. So I'll give a few examples. If you look at the attitudes of mindfulness, if I take, the 7 ones that we're often taught, two words, 2 terms that really are tough ones or have to be introduced very gradually in a certain way, the idea of letting go and the word acceptance and the word acceptance.
Wow. Yeah.
So if you bring in the word acceptance on the first or second session with a group of chronic pain sufferers, you can be guaranteed that 50 to 75% will not show up the following week.
Wow.
Anyway, you try to cushion it afterwards. And it's funny because often somebody actually in the group will bring in that word because maybe they know a little bit about mindfulness, and I always kind of tell them, listen, I'm going to try to not use that word. I'm very cognizant of the fact that acceptance is actually so fundamental in mindfulness. It's particularly important in chronic pain management. So although we are certainly working towards acceptance, just the word acceptance can be particularly difficult to hear. So acceptance, letting go, we will often try to maybe transit to letting be rather than letting go. Because again, bringing it back to maybe we can talk about this further later, but the experience of chronic pain and the repercussions of chronic pain, often patients will report not so much that the pain or the physical sensation of pain has affected their life, but it's all the other things. So it's all the repercussions. It's all the losses, the griefs, the functional impacts. So when you start using words like letting go, you'll often get pushback. I'm not ready to let go. I'm not letting go of that because this has such an important impact on my life. Mm. So those are a couple examples of things that we've learned along the way in terms, at least, of languaging. I've got others that come to mind, but maybe I'll let Jackie jump in here if you want.
Yeah, there's just so many things. I think in the early days of my training in mindfulness, I was also, I understand it differently now to the way I did then. So my understandings have evolved. But I noticed in the first couple of years that if you always tried to spin something to the positive, that was a really bad idea with this population because they needed the acknowledgement that things were pretty negative for them. And so to try to always take something they said that might sound really negative and black and dire and find something positive in it straight away was not where they needed to go. And others would really be on board with that. And what was interesting was it didn't lead them necessarily down the path to more negativity. It just gave them the space to share with you as the facilitator that things had been pretty bad, especially if they had trauma in the past, and to be with that, to acknowledge it, to validate it. That was the thing, to validate it. And then they could move on. So in a sense, it was using the A word, and my groups tended to use the A word because they didn't like the word acceptance. So acknowledgement was a better word. And there were some sort of slightly gentler words we could find that still began with A. So that was kind of where they needed to be, to validate the negatives that they had, and then that they could use that as a springboard to something that might in fact get positive in the future. And in fact, in our course, towards the end of the course, we had creative work time where they may draw some pictures, do some art, do some collages, whatever they want to do, even compose songs that were the brain's way of expressing their chronic pain other than through language. Tremendously enlightening, but some of that art was very dark. Mm-hmm. And I would worry that the others would feel terrible about seeing this. And interestingly, they could be really dark with the art, but they could be beaming that they had done it and that they were using it to validate what they've been through. Others could relate, and they would often then move on past it and start to do more creative work later on after the course had finished that would lead them to the next step and the next step of recovery. So that was kind of interesting as well. In addition, the word compassion is tough for them. Compassion and self-compassion are words that they are not ready to sort of contend with, especially in the earlier part of the course. They don't feel they deserve it. They feel it's too quick and too trite for them. And so we also have to look for words that might mean the same, but are words that are more acceptable to them.
I'm really glad you're bringing in this piece about not needing to go towards the positive and the potential benefits of that. It makes me think of, within trauma-sensitive practice, the ability to dignify someone's experience and our own window of tolerance, that if we can't tolerate as providers someone's emotions and try to actually just put a bow on it or deflect, that's actually not supporting the person. And I just, the relief of that, you don't have to try to make anything better in a moment as a provider, but to let someone have that experience. I can understand why it's counterintuitive. Like you think, oh, it's just going to keep deepening them into the dark hole that they're in. But actually, in fact, by letting them be with that level of pain, I know when I have that, just when someone's just willing to let me be in that, it opens the possibility of something else. So this feels so rich. Can you either of you talk about more, what else would you want us to know, this community, about chronic pain? Again, it's a very unique situation where you're both talking about real nuances here around language, shame, families. You were talking, Alan, about the emotional impacts as opposed to the physical. What else would you want us to know about what you've learned and how you're working this inside of the mindfulness program?
The big one is the body scan. Alan, do you want to speak to the body scan about how there's the inattention that we found out?
Yeah, I'll give you the context, because as I mentioned in the beginning, I knew mindfulness based stress reduction. I knew body scan before I really knew the chronic pain population. It was kind of the first thing I thought to myself: how are we going to introduce mindfulness to a group of people who generally, I mean, more than generally, a chronic pain sufferer's relationship with their body is a really complex relationship. And although I at the time, I think had a certain understanding of the importance of why we do body scans and the importance of using our body or bringing our body's our mind to attend to the body as an anchor, I also realized that with chronic pain sufferers, that really is going to be a much more layered place or layered context to put our mind. So one thing that Jackie did with the program for sure was, first of all, delay where the body scan is introduced. So a little bit, like I said earlier, just as much as the word acceptance, I think, will clear the room pretty quickly. If you bring body scan in day one with a group of chronic pain sufferers, it for many will not go over well. So we introduced in the program much later. There are many modifications that there are in the program. One of them is that the program is typically longer. It's over 12 or 13 weeks. And even within that 12 or 13 weeks, it allows us to introduce concepts in a more gradual fashion. By the time we're about halfway through the program and people hopefully have a better understanding of what mindfulness is, what meditation is, at that point, they are maybe able or more prepared to start exploring the body scan. They've hopefully been able to integrate a certain understanding that mindfulness or meditation is about bringing your attention to something. The piece about non-judgment, because again, the judgments about the body are immediate. So you can imagine with the body scan and someone who's had this kind of relationship with their body that has not been a positive one, you really have to have some kind of grounding and understanding of what non-judgment is. So having said that, gladly, and the body scan was not removed from the program. On the contrary, it's such a valuable and important piece of the program, but it's really about the timing of when it's introduced, the preparation bringing us to that time. It's also about the preamble, so we're careful about how we introduce what body scan is before we actually introduce it. And then, of course, the debrief that follows its introduction, which is key to helping people navigate whatever is coming up.
Could either of you talk about that introduction that you do when you talk about the body scan? I'm wondering if either of you could talk through that for a moment, because it seems like a needle to thread around you're bringing in something that's potentially dysregulating or destabilizing, but you don't want to fearmonger at the same time. I'm just wondering if you could talk about how what you just named, Alan, I think is hard to do. And to do that well. It sounds very intentional, and I'd love you to get to unpack it a little bit.
Well, part of our trauma-informed, trauma-sensitive training is around preambles for any of the meditations, but particularly body scan. And the preambles are in order to ensure that if somebody is in the middle of a formal practice going down a negative route, that they don't feel like they're failing, and that there is a precedent set for this by saying, some people have found when doing this practice that some negative things can arise. And so being gentle with the languaging and not covering everything that might happen, but it ensures that people don't suddenly shut down in a practice because they think they're doing it wrong or they think they failed in some way. And body scan particularly has to have a gentle preamble to introduce the fact that they may skip over some parts of the body as it's being related, and not to feel like that's abnormal. And in fact, it may be the part of you that is the most disabled or the most in pain. What I found out later, much later, probably 2010 to 2012, I suspected that people were certainly jumping over the part that was disabled and not paying it attention because it was too painful emotionally to go there. And then I found out that in reality, everybody with chronic pain in certain areas of the body pays less attention to those areas of the body. Mm-hmm. And one of the therapeutic ways that you can reduce pain is to put the brain back in touch with the body in those areas, because the inattention is in the brain. That brain tissue is reducing in density, so the connection has been reduced. Once we are strengthening the connection with the parts of the brain that are connected or should be connected to that part of you, then pain seems to decrease. And we've had instances where people manage their pain by doing the body scan every day, and that keeps their pain down and keeps their medication requirements down.
Wow. I mean, this seems like one of the core contradictions when I first learned about MBSR was someone would say, well, why would I want to pay more attention? Why would I want to reestablish connections? I'm avoiding that part of my body for a reason. And yet it seems like in partly the avoidance can actually create more pain, like this pain paradox. So how do you, if someone comes to you, either of you, and says, why would I want to pay more attention or establish that connection? I'm curious how do you both handle it?
So, the quick answer, and I'll elaborate. The quick answer is that it's not really about paying more or less attention to our body, but it's the quality of attention that we're bringing to our body, and the that, I probably wouldn't use those words as an introduction, but it's certainly the kind of languaging that I would use sort of once we've established some basic concepts of what mindfulness is. So yeah, I say straight out to my groups of patients, like, at this point, you're probably wondering, I'm going to ask you to bring attention to your body, and you might be wondering, no, it's okay. I'm an expert in that. I hear my body loud and clear. You don't have to teach me how to do that. But when they've already had some concepts of, well, no, we're going to bring our attention, and although I know you hear your body and you're very attentive to it, we're going to try to bring attention to the sensation in our body, but in a different way. And they've already had some training into distinguishing, to a certain extent, what is a real body sensation, what is thoughts around that body part, what are the emotions around that body part. So there's already some kind of understanding that although it's not always easy to, in a live way, to be able to break that all down, but that those components of the physical sensation are different, and that the pain that they're feeling, or I should say the suffering that comes from the pain, yes, is in part related to the physical sensation, but also has to do with the thoughts and the judgments and the emotions. So when you've kind of laid that framework out, it really is an interesting exercise that I think most people are then able to do and sort of disentangle what is the actual physical sensation and what is all the other stuff around it.
And some patients get very hyper aroused, very dysregulated when they first encounter body scan, because some of them do say, I've been taught to ignore the parts of me that are causing my disability and are causing my suffering, and you're trying to tell me to go and look at them and be with them. So sometimes there is, but if you do a good preamble, it's going to reduce that reactivity. So it's going to keep the whole group a bit safer if you do a good preamble. And we do talk about, as pain becomes more chronic, we tend to shun those parts of ourselves because we're disappointed in them. So we normalize it. Of course, we're disappointed with them, and some shunning may occur. And this does, from experience, we find this does seem to allow the body and brain to sort of reconnect in those areas. Mm-hmm. And in reconnecting, there can be more safety around moving that area of the body. We're sort of connecting with it in such a way that we are nurturing it again in ways that perhaps we've let go of. Yeah. So, and actually, there is a precedent for this in strokes that can occur, which cause you to have inattention for a part of the body, or complex regional syndrome, where it's thought that there is an inattention towards that part of the body. So, and there's research to show that those parts of the body that are in pain have poorer discrimination. If you put 2 points on that part of the body, they won't be able to tell the difference between 1 point and 2 points, whereas somebody who's pain-free in that area could tell the difference in terms of the closeness of the 2 points. 2-point discrimination is what we're talking about in that, and research has been done on that. So I believe that the body scan is actually performing a really good function in getting people back in touch with those painful areas such that they are managed better and the pain decreases.
If I can just add one thing, David,
yeah,
back to the question, your original question, and I think this is part of the teachings that I've seen you give as well, is that, of course, that's sort of the idea behind the body scan, but it's a very important part of the preamble that we acknowledge that some people are just not ready to go to that part of their body. And even going further in the same way where, I remember once hearing you talk about people that dissociate, and that's their way that they've been, that was their coping mechanism. Kind of saying, well, that's fine, that's good. You're not going to that part of your body. That's your way to manage and cope with it, and that's fine. Opening the door to maybe now, or maybe in the future, maybe when you're ready, exploring that further might be important as well. But it totally makes sense that up until now, that has been a mechanism. You've been distracting yourself. You've been ignoring that part of your body. That absolutely makes a lot of sense.
That's great. Leaving people, we definitely will be talking about that in the course around choice, just being this core principle, and still providing some guardrails and some encouragement. Like, there is a structure that you're both offering in the work and that you're asking people to stretch. and how to do that. Now, I was actually thinking I wanted to ask you both this, that both when you were talking, Alan, especially when you were talking about the preamble to this invitation to be potentially reconnecting with areas of pain in the body. In my experience, both before this session with you both and now, is that you both embody, I'd say, a real trauma-informed, you both embody trauma-informed practice to me. In that, Alan, I was imagining being someone in chronic pain, and that I went to you and I said that, like, why would I feel this? And I was listening to you and I thought, you're not coming across, either of you, as sort of on a soapbox, top down. This feels like an invitation that you're making to experiment, and that I'm in choice to do it, but that you've found that this has been useful for you as a physician, as a teacher. And I'm wondering if you could talk about, for either of you personally, what has supported you to really deepen that kind of invitation for people? Inside a trauma-sensitive practice, I think it's that, we've each done, the more that we've done our own work, the more that we're able to invite people into different aspects of practice, not get triggered if they don't want to do something. But around chronic pain in particular, I don't know if either of you have had chronic pain. I just imagine you've worked with lots of people. Like, what's supported you to be as embodied as you are around this particular subject?
Okay, so I'm a migraine sufferer, and doing this work, and I did it intensely for years. I would run like 5 concurrent groups a week sometimes, wow, which was too much, but I didn't like one-to-one practice anymore. I've always felt that the group work gave me the most satisfaction, because I could see how important it was that the group supported each other and the healing that could occur. So there was a huge sense of accomplishment at the end of the groups, because you could visibly see people change along the course. It was also very important to do a lot of the attitudes of mindfulness ourselves in non-striving. Yeah, you can't force somebody to quicken their rate of uptake of what we were teaching. However, it's important to understand that we may set them off on a path that they can continue to follow themselves. And 2 years later, if we encounter them and we haven't seen them since, you can see a huge difference in some of these people that have really run with what we have given them to start with, what they've run with the mindfulness practice. And that's so wonderful. I've had people say to me in the supermarket, I'm off all my medication now. I still hear your voice, because some of them still choose to listen to the tracks, and some of them are doing silent meditation. The change is so great compared to the way it used to be using conventional medical interventions, that it's really, I hate to use the word addictive, but in my retirement years, I'm still running the trainings for this course, because I believe in it so much, and I believe that the health system needs it. So I guess, but it is important to let people go at their own rate. It is important to let go of the need for absolutely everybody to benefit, because some people won't. It's important to recognize that there may be 10% of your group that do fantastically, and a middle ground that are doing better, but they aren't doing fantastically. So there's a range of how people are doing, and they're all walking at their own rate through this practice. And some will give it up as soon as the course is finished, and they'll say, I'll just be mindful, but I won't do formal practice, which is sad, because without formal practice, they will not make the changes that we are looking for. Alan, anything from?
What I would say is I run groups, and I still do traditional chronic pain management work. So what I mean by that is I still see patients one-on-one. And it's interesting, because what we're called upon to do when we're seeing patients one-on-one is very, very different. Excuse me. And the medical model certainly does not lend itself typically to this kind of intervention. Having said that, I certainly, aside from the group work that I do, I really try to bring this kind of approach in my individual interventions as well. And what that looks like, I mean, there's many layers to it. Part of it is just being aware that when my patient's pain is not as well controlled or their suffering is increased, typically a chronic pain physician will tend to look towards, have there been any physical triggers? Have you lifted something? Has there any, and we're not really trained to go further and ask, well, what else is going on in your life? Are there any other stressors? So one is about tailoring the way I approach it, looking at those things and helping my patient also be more aware of those triggers. On the other hand, it's also being aware of myself in the interaction, which is another interesting one, because again, physicians are trained to provide answers to questions, right? Your patient asks you a question, you give them an answer, and I'll often give them as an example. If you ask me, what are the typical side effects of a medication? I'll give you the answer. I know that answer. If you ask me, why is my pain more out of control? It really is an extra step for me to sometimes just sort of sit on my hands and realize that I don't have the answer. I can try to help you maybe know where to look, and sometimes I won't know. And sometimes it's really about allowing you to be comfortable with not having the answer, but that starts with me allowing me as a physician being comfortable not having the answer as well. So it's a real shift in the way we traditionally practice, but I think it's a shift that's so key to really truly helping our patients.
It's great. Yeah, I can see there's just so much to learn inside this field around chronic pain. And, given that we're having this conversation as the novel coronavirus is really impacting the world with the pandemic, and there's been this shift to more online programming, I'm wondering I'm sure there's a number of people in the community who will be also making this shift, and I know it's something that you're both making. Can either of you talk about, does this program work online? What are you learning about it, and kind of best practices there?
So around 2003, because the pain clinics in Toronto have a very large catchment area, I really needed to be able to reach out to those who are in smaller, faraway Ontario communities and provide the program through telemedicine. And so one of the two teaching hospitals I was at, Sunnybrook Health Sciences Centre, had the telemedicine capabilities, and that's what we did. We had a small group in my room, the telemedicine room at the hospital, and we were connecting with 2, 3, 4 sites across Ontario at their health centres. And I mean, the very first group that I had was in Wawa, which is like miles away, like very long way away. So we set out to do measurements like pain catastrophizing constructs and quality of life, the SF-36, the pain score, of course, and a suffering scale. And we looked between 2004 and 2006 at those data sets coming in, whether they were distant site or on-site with me. And we were able to show that the improvements were statistically significant, especially for the pain catastrophizing constructs, and they were almost as good off-site as on-site. You could also see that usually there was a coordinator at their ends who was kind of floating around, or sometimes in the room if we were lucky, and I would get notified if people were dysregulated, and I might not have been able to see that. So they were very vigilant at that. But also, I think with practice, it's possible to become more aware of dysregulation going on at your distant sites. And now I teach learners the program through online. And one of those training courses, trainings at the University of Toronto, is the same as the patient's course, so they can experience it online, even though they're healthcare professionals, but they haven't seen this course before. So they're kind of acting like patients, and many of them do have their own chronic pain, by the way. I think that tends to flush them towards us. So I've done quite a bit of online, And I prefer it. It's the same as with Zoom. You can see people quite well. And I've been able to pick up dysregulation through the TV screen reasonably well. There are clues. And I think the more mindfully trained you are and the longer you've been at it, you're probably more discerning to be able to pick up the dysregulation and to be able to find the careful languaging to intervene and see what's going on. And of course, giving choice all the time. Choice is so important about, can we explore that? Or would you like to speak to this right now? And to be very respectful of when they're not ready.
Alan, anything you want to add there about your experience on telemedicine?
Sure. I mean, my experience is much more limited than Jackie's. The only thing I guess I would add is that, interestingly, in the context that you're talking about, so I'm running a couple of groups right now, and we were halfway into the program, really important piece. And when all of this came up, I reached out to everyone, kind of wasn't even sure myself, are we going to continue? Are we not going to continue? And what's been interesting is, I would say pretty much universally, everyone I've spoken to in my groups, and this is quite a few patients, the reaction that I had was absolutely, if you do this online, we want to continue. They recognize the importance of having the group. They recognize the importance of continuing to work on their pain management. And they also recognize how the challenges that we're all facing now and going forward is having a direct impact. And some of them have already said, listen, I'm only halfway through the program, but I already saw the benefits. And I think this can be something that can be so important and valuable and supportive going forward. So I'll have probably more to say on my experience once I get these all running. But it was interesting to hear that's what people are asking for.
Yeah, that's awesome. I mean, yeah, we can keep in touch, keep talking about what you're both learning. In a moment, I'll ask you how people can get in touch with you and your online work. I just want to open it up. Is there anything that we haven't gotten to talk about? I realize we could talk for hours here, but anything in particular that we didn't touch on that you'd like us to know about?
I think, yes. I think as I got more into doing mindfulness work, I recognized that these patients were highly sensitive people. More so than the general population. There was a bigger proportion of them in the chronic pain world, and that there was indeed a lot of childhood trauma in their pasts, and that they were perhaps reacting to pain, illnesses. Maybe they were becoming ill because of the ACE, the ACE work that's been done that shows that with childhood adversity, we are more prone to developing certain illnesses in the future as adults, and these can be painful illnesses. But if it was through an accident or an injury as well, there is a different reactivity in that population. Highly sensitive people who've had difficult experiences in childhood and didn't have the parental supports. So I was beginning to see, even in my practice in the clinic, that 90 to 95% of those I was seeing had a story of childhood adversity that impacted them. And that's the important thing, that impacted them. And so as they were coming into the groups, that did require more expertise with the languaging and the being really nuanced, insightful about how we rolled this out and how we responded to things that might appear strange, and how we normalize strange responses or odd behaviors, but how that all becomes normalized in these groups, and how we role model that for the others in the group as well. So that's important.
If I could just add to that, and I think it speaks to probably how, Jackie, how your program empirically really became an embodiment of trauma-sensitive and trauma-informed practice, in that realizing that chronic pain sufferers, and it actually makes a lot of sense to what I was referring to earlier. So I talked about central sensitization, how chronic pain sufferers seem to have a nervous system that's just highly reactive. Well, from my understanding of trauma and the impact of trauma on the nervous system, there's definitely a relationship there. So it makes empirical and practical sense that an approach that will be aware of the heightened reactivity and heightened sensitivity of the nervous system that is, embodied in a trauma-sensitive practice will be all that important and in a chronic pain population as well.
It will, and it's also important for us to acknowledge the research that shows that people have polymorphisms that can create a higher tendency towards being more sensitive to pain and being more sensitive to stress, in terms of how quickly stress hormones are broken down. But that's also paired with the parenting, so that you can have a predisposition to high sensitivity to stress and pain, but if the parenting was very good in its role modeling and support, it kind of mitigates that genetic predisposition. But the opposite is also true, that if you're highly sensitive, poor parenting will likely make this worse, the predisposition, and create a reality. So it's going to be very interesting to sort of see how that research unfolds.
It's fascinating to me, all the different factors that we can be discussing. And then in this moment of the pandemic, that I've been talking about the way that this is going to push on the collective window and what are the resilience factors that will support families and communities, which won't. There's just so many different factors that we're talking about. And it has been really helpful to get to dig into chronic pain a little bit and talk about this particular domain that you've been both doing work within. Can you talk a little bit about if there are people that want to get in touch with you, how can they find you?
Well, they can find us through the site that we've created, because I run a company called Neuronova Center for Mindful Solutions, and it's a company to train others to deliver our courses to patients, to clients. It can be in a corporate setting, but mostly it's in a health setting. And they can find our facilitators listed on our website. I wouldn't say our facilitators, it's more like a franchise model where they come and train, they take it back to their own communities, and there are some in the States now, as well as the most would be in Ontario. Alan's pioneering it in Quebec, and so he's on our website as well for that. He does it in French and English, by the way. Mm-hmm. So we do have the French version. And then there are others across the country in other provinces are beginning to take it up. In addition to which, we are teaching trauma-informed, trauma-sensitive strategies at University of Toronto School of Continuing Studies. So we link to that. For mindfulness instructors in general. So we do have a program which is we are using it as a prerequisite, aren't we, for your advanced program as well, David, where our little weekend program, which is 12 hours of training in trauma-informed, trauma-sensitive strategies, can feed into your advanced program that you are about to start running, which we're all excited about. So, Neuronova Center is a key word to put in. We're at neuronovacenter.com, or even just Googling my name, Dr. Jackie Gardner-Nix, would probably take you to it as well.
Perfect. Alan, they can find you that way too as well, it sounds like.
Yeah, that's probably the easiest way to find me for that work, yeah.
Okay, that's great. Well, thank you both. In the midst of all that's happening right now around the pandemic, I just appreciate you both taking the time. It's great to hear more, and I imagine to be continued in the months and years to come. So thanks again for being here.
And thanks for your interest, David.
Well, thank you, David.